Sir, it's already sharp 7:30. With all of your permission, I'm starting this session.
Okay.
Good evening, everyone present here. I welcome all the participant doctors on today's session. Let's welcome today's speaker with great honor, Dr. Pratik Tripathi, sir. Sir has done MBBS, MD Medicine, DM in Nephrology, and Head of Nephrology Department at a multi-specialty hospital, Fortis Escort Hospital, Jaipur. Today he is going to discuss on a topic chronic kidney disease. Let me tell you overview of the topic. The classification and definition of the CKD, that is chronic kidney disease, have been changed over time. But according to the most recent interventional guidelines, this condition is defined as having at least 3 month history of kidney damage, a glomerular filtration rate, that is GFR, or less than 60 ml per minute, 73 M2, or markers of kidney damage. The incidence, prevalence, and development of CKD also differ between nations based on special determinants of healthy and ethnicity. The preferentially due to the influence of the epigenetics. Join in this session, the Dr. Pratik sir will be going to discuss about it. Now, I would like to invite this sir and hand over this session to you. Over to you, sir. Kindly proceed from here.
Yes. Yeah. Good evening, friends. Today, uh, as a nephrologist, I would be talking about something that I come across every day, and which is chronic kidney disease. Uh, Next slide, please. Next slide. Yeah. Now, basically, we'll be touching exactly what chronic kidney disease is, and then I'll talk about why it tends to progress. Now, chronic kidney disease is a renal disease or a kidney disease which is actually incurable, which is progressive, and uh, you know ultimately ends in dialysis if the person survives long enough. Now, there is a theory which was brought initially by Brenner, which talked about the number of nephrons being conserved at the time of birth. So, all of us are born with a number of nephrons. It's like having money in the bank. You're born with some money in the bank, and this amount is fixed, and you are supposed to spend the rest of your life using this particular amount. You can't add to it. So the number of nephrons is set at birth, and it tends to decline with age. Now, with old age, what happens is, you know, the filtration load and the metabolic activity also declines, and there is no change in the kidney dimensions, and the nephron size also does not change. What is known as the single nephron GFR uh, also remains unaltered, and the level of proteinuria remains within the normal range. So this is what is known as non-pathological aging. This is the normal process of aging. However, there would be situations where the number of nephrons, they are declining, but the work being done by them or is remains high. So what are these situations? These situations are like obesity, like pregnancy, and any renal disease where the number of nephrons are reduced in number. So what happens? There is a mismatch between the filtration load and the number of nephrons. So logically, the single nephron GFR increases, so does the proteinuria, because hyperfiltration. There is hyperfiltration at the level of each nephron, and then adaptive. If this continues for a long time, adaptive changes occurs. That is, the glomeruli and the tubules, they increase in their size. In diabetes too, similar changes occur, and uh, the whole pathological process is driven by hyperglycemia. So ultimately, at the end of the day, what is happening is that chronically high single nephron GFR culminates in shortening of nephron lifespan. In other words, it this becomes a process of attrition by which the number of nephrons get reduced uh, drastically in a faster rate than what is so-called natural. Now let us exactly see what chronic kidney disease is. Next slide, please. Next slide. Next slide. Yeah. So, chronic kidney disease at the end of the day is a functional or an anatomical abnormality of the kidneys which would last beyond 3 months. And what are the things that we are looking at when we talk about the so-called abnormalities? We are talking about proteinuria. We are talking about hematuria. We are talking about pathological abnormalities. For example, when you do a biopsy and then you do another biopsy 3 months later, and they are if these abnormal changes are still around, you would by definition call that chronic kidney disease. And of course, radiological abnormalities, like uh, for example, if the kidneys are scarred or there is, cysts in the kidneys and they last beyond 3 months, then you are talking about some abnormal changes. Another thing that I would like to point out is if someone has a single kidney, by definition, that person has chronic kidney disease, even though the fact remains that that single kidney may be totally normal, but he would be predisposed, he would be at high risk of having uh, uh, renal problems later in life. So a kidney donor, by definition, is a situation where an iatrogenic CKD is being produced. Next slide, please. Next slide. Now, there is a lot of controversy regarding the radiological criteria for CKD. We understand that in most cases of CKD, because of the attrition of the number of nephrons, the kidneys tend to shrink with time, and there is a lot of scarring and fibrosis taking place in the interstitium. So the kidneys would actually shrink with time. So this criteria that you see here being depicted is basically from Western literature. So their average kidney lengths are around 10 centimeters, more than 10 centimeters. And according to them, if you add the length of one kidney and the with the length of the other kidney, and the total length is less than 20 centimeters, then you are probably looking at abnormally sized kidneys, that is small kidneys. There is something known as the kidney length and body height ratio, which is the KBR. And here the kidney length in millimeters is divided by the body height in centimeters. And for those adults less than 60 years of age, uh, with normal kidneys, the range should be between zero point 0.6 to zero point 0.7 for the left, and between 0.5 7 to zero point 0.7 for the right kidney. So, I mean, for Indians who are obviously shorter than the Western people, maybe this criteria may be used. Also, if we talk about cortical thickness, that's also very important. So, normal cortical thickness is approximately 8 to 10 millimeters. Also, echogenicity. So, usually, how do you distinguish between acute and chronic kidney injury looking at the ultrasound? If there is a lot of echogenicity, if the kidneys are highly echogenic, then you wouldn't be wrong in guessing that probably you are looking at pathological process which is quite advanced and has gone beyond the realm of so-called acute kidney injury or acute kidney disease, and has probably progressed to chronic kidney disease. Uh, Next slide, please. So this is the epidemiology of CKD. In fact, approximately 10 to 11% of population, random population, would have CKD using the previous definition. Uh, in other words, if you have 100 people, out of those 100 people, almost 10 or 1 out of 10 people would have chronic kidney disease. In a room, if you have 10 people, maybe if you toss a coin, there is a possibility that one of them has chronic kidney disease. And you can see uh, this is an iceberg, um, and it most of it is submerged. That is, most of these people, they have stages. They are in stages which are not symptomatic, and in fact most of them are not even aware that they have chronic kidney disease. It's only those above the surface with more advanced disease, those in stage 4 and stage 5, who have become symptomatic and who have uh, you know gone for medical opinion. They are there in the open, and they are recognized as people who have CKD. So you can see there are plenty of people who have CKD and they wouldn't even know about it. Next slide, please. Next slide. Yes. So whenever you encounter CKD, you have to classify it as well. And so classification is based on the so-called EGFR, or the estimated GFR. We have formulas. I'll tell you about those formulas that can be used to classify someone as having, in which class he is. So you can see uh, um, to this, another thing was added, category according to albuminuria. It was felt that those people who are more uh, proteinuric, who are having a lot more proteinuria, tend to have more greater or faster progression and tend to have more cardiovascular disease. So it was felt that albuminuria should also be incorporated in the classification. You can see that there is a lot of red here. So people whose GFR is more than 90 with the high grade proteinuria would have some degree of risk of progression, as evidenced by this orange. And however, if they have no proteinuria or normal raised proteinuria, it would be green, that is, they are safe. And you can see those people who have advanced disease and who have high grade proteinuria, it's all in the red. So these people are uh, are at greater risk of progression. Not only that, they are at greater risk of developing cardiovascular disease, and they are at greater risk of dying. Next slide, please. Next slide. Next slide. Yeah. So these are the causes of chronic kidney disease. In most cases, in the Indian context as well as the Western context, we find that diabetes mellitus is a major culprit. 30% of people who are on dialysis in any dialysis unit would have underlying diabetes mellitus. Hypertension, it is, though almost all chronic kidney disease patients have hypertension. Some have uncontrolled hypertension, but if you want to uh, you know uh, uh, keep hypertension as the sole cause of CKD, then probably it comes down to about 10% or so. Then there are other entities where you have chronic glomerulonephritis and tubulointerstitial disease. In the Indian context, especially in Rajasthan, you have a lot of renal calculus disease, which causes tubulointerstitial disease. And then you have a hereditary cause, which is, quite common, quite common in the sense that, 10% of people on dialysis have autosomal dominant polycystic kidney disease as an underlying cause. And there are other entities which are much rarer. Next slide. Next slide. So These are the risk factors which are associated with chronic kidney disease. They have been divided for convenience into so-called susceptibility factors. So if these factors are present, the person would be at risk of having chronic kidney disease. In other words, if these factors are present, then there is a chance that that person would would be at risk of getting CKD. So old age, family history, kidney mass reduction due to surgery, for example, uh, and low birth weight, racial minorities. For example, in the US, they have found that the African Americans are at particular risk. Low income groups, and of course, which go hand in hand with minimal education, no matter where they are, in whichever part of the world, would be at high risk of CKD. And then you have the so-called initiation factors. These factors are the direct culprits. So you have risk factors followed by factors which actually cause the disease, like diabetes, hypertension, autoimmune disease, infections, including systemic ones, and UTIs, stones, drugs like painkillers, and obstruction because of so many reasons, prostate, for example. And then once CKD is there, then if these risk factors are present, then they would signify, or they would tell you that this person would have a more rapid progression of disease compared to someone who doesn't. So what are those risk factors? These are the proteinuria, as I mentioned before. uh, More the proteinuria, the faster the progression. Higher blood pressure. So someone who has uncontrolled blood pressures and has CKD, you can be sure that person is going to have a faster progression. Poor glycemic control. Someone with diabetes mellitus with DKD. So diabetes causes is an initiating factor and is a progressing factor as well. So here you are. Smoking. So CKD people who continue to smoke, they are asking for trouble. Now, those who have gone into the end stage, uh, these factors basically are telling you about the morbidity load. So, people who are already in the stage 5, that is a EGFR of less than 15 ml per minute, if they are not getting good dialysis, if their access is not up to the mark, vascular access, if they have anemia which is uncorrected, if they are malnourished as evidenced by low serum albumin, or who have high load of inflammation, and late referral, I mean, not getting the treatment at all. These people are at high risk of dying. Next slide, please. Next slide. Yeah. So here is something briefly about the so-called racial predisposition. The access to healthcare and socioeconomic situations and compliance, cultural barriers. These things generally apply to people in the third world who are, you know, backward per se, economically backward. But when we talk about racial predisposition, we are also talking about these particular groups also making the bulk of the people who are not doing economically well in the places like US. So genetically they would be blacks, African Americans mostly, or even people of other racial groups, and they would have all the other problems associated with it. But African Americans have a problem like the Apple one mutation, which is an apolipoprotein, and apparently it evolved in Africa to protect them from sleeping sickness. But it turns out that this particular lipoprotein was involved in a lot of other things as well. And then because though they would survive the sleeping sickness, they would be more predisposed to having renal disease. Next slide. Next slide. In fact, you can see a black African who is donating kidney is at greater risk of having CKD himself or herself compared to a person who is not uh, black African. Next slide. Next slide. Next slide. Next slide, please. Yeah. So ultimately, at the end of the day, who are the people that you should keep in mind when the patient comes to you? Who are the people where you should think about this particular issue, that is CKD? So these are the people who have diabetes mellitus, people who have hypertension, who are obese. Next, please, the previous slide. Previous slide. Don't change the slide. Don't change the slide. Yes. There is a whole list. All of them are at high risk of CKD. So old age, those who have had previous history of acute kidney injury or who have been hospitalized, people who have a family history of chronic kidney disease, people who have unexplained edema, people who have cardiovascular disease as well. Some people like those having heart failure, for example, you should always screen for the possibility of underlying renal disease as well. Those who have vasculitis, SLE. SLE is famous for causing lupus nephritis. Those who have a bladder or a prostate problem, those who have stone disease, you should always do screen them for renal disease. And those who have been exposed to certain drugs, for example, painkillers, and some people like lithium. Lithium. I've had patients who had manic depressive psychosis and who had been on lithium for years, and then they start having problems, and they come to me, and I find that they have underlying CKD because of lithium. Next slide. Next slide. Yes. So how do you screen them? So you basically do very basic test. You do a urine routine test. Please. Yes, you do a urine routine test where you do a urine routine test where you do a microscopy. So you are looking for protein. You do a dipstick. You use a dipstick. You look for protein. You look for RBCs and WBCs. And if you find RBCs, WBCs in the dipstick, then you do a microscopy to check what kind of RBCs and WBCs you are looking are there in the urine. And of course, when you find protein, then ideally you should be doing quantification as well. That is spot urine protein uh, creatinine ratio or an albumin creatinine ratio. That is basically looking for micro albuminuria. And you do a creatinine test as well, and you can use this creatinine to calculate the estimated GFR. And the estimated GFR is can be you can use two formulas. Please, next slide, please. Next slide. Next slide. Yeah. This is a bit about creatinine, where it comes from. Basically, creatine is located in our muscles, and our muscles, uh, it is converted to by creatine kinase into phosphokinase, and phosphokinase is a reserve thing, like almost like ATP. So it stays there with energy. It's an energy reserve, and whenever you are using your muscles, it gets converted back to creatine and produces ATP. And both of them spontaneously got converted to creatinine by by a non-enzymatic reaction with water. So creatine gets converted to creatinine in a very steady state. Just because it is lying there in the water, it gets degraded into creatinine, and this creatinine starts basically comes out of the muscles into the leaks out of the muscles into the blood, and this is what we are measuring, and this is what is excreted by the kidneys. And when the kidneys are not functioning, this level goes up, and that is what we are using for estimation of the so-called GFR. Next slide. Next slide. Yeah. So these are the two tests, the MDRD test and the CKD EPI test. And now we have another test, which is the so-called, which doesn't do racial profiling like these tests used to do. That is, you don't have to put the race of the patient, which is the latest test. And then you have something known as creatinine clearance, which can be calculated by Cockcroft-Gault equation. This can be done at the bedside, or it can be done when the patient comes to you, and you can do it on your own uh, without even using anything. So this is what we tend to use when in the clinic, unless you are using a computer. Uh, Next slide. So what do you do when you find that someone has abnormal tests? So the creatinine is high and or the urine is abnormal, then the criteria has to be satisfied. If these things have been present for 3 months or more, then basically you have a person with CKD sitting in front of you. So what do you do next? So you try to figure out why he got the CKD in the first place. So you look at the so-called initiating risk factors. You looked at the previous risk factors, the causes, the underlying cause. You try to find out whether he's diabetic, whether he's hypertensive, whether he has been taking drugs, or whether he has got an obstruction, whether he's got a stone, whether he has had repeated infections or acute kidney injury in the past, things like that. You try to figure out the underlying cause. You try to figure out aggravating factors, factors which would cause, which would worsen renal functions. That is the acute factors, and of course you assign the category. As I said, as I pointed out, you have the G1 category where the EGFR is more than 90, G2 between 60 and 89, G3A between 45 and 59, G3B between 30 and 44, G4 between 15 and 29, and G5 that is less than 15. And you assign an albuminuria category as well. So there are three categories here depending on the level of albuminuria. It gives you an idea as to how quickly this person is going to progress. So the more the proteinuria, the greater the chance that the person is going to progress. And in case the criteria are not satisfied, then you can tell that person to come back later on, uh, so that the screening can be done again and again. Next slide. So what are the symptoms of so-called CKD? So the symptoms CKD are basically because of the accumulation of uremic toxins, and our kidneys, they are excreting a lot of toxins which are produced during metabolism in the body, and they're involved in lots of other things like hormone production, like activation of vitamin D, erythropoietin, and taking care of the metabolic milieu, basically taking care of the acid base balance, the electrolyte composition of the body fluids, taking care of the blood pressures, so many things. Um, so when things start going wrong, then symptoms would naturally occur. But unfortunately, symptoms tend to occur rather late. Most people start developing symptoms when the creatinine clearance is less than 45, less than 45. So early symptoms when it's less than 45, and somewhat more symptoms when it's less than 30, and when it touches 15, then things have really bad. So because these toxins accumulate in the blood and the changes take place in the body fluids throughout the body, so every organ in the body gets affected. So you have psychological issues. These people are psychologically, they have problems like anxiety, depression. They have cardiovascular issues like hypertension, heart failure, pericarditis, pericarditis, myocarditis, and gastrointestinal issues like anorexia, nausea, vomiting, uh, constipation, sometimes diarrhea, bleeding, a lot of things. Endocrine, lot of problems. Hyperparathyroidism, thyroid problems can also occur. Infertilities occur. Sexual dysfunction is pretty common. Uh, Metabolic issues like carbohydrate intolerance, nutritional deficiencies, gout can occur sometimes, rarely, and hematologic and anemia is pretty common. Infections tend to occur because the immune system gets affected. Neurological issues occur, like um, confusion, sedation, myoclonus, seizures, things of that sort. Ocular problems also occur because of the hypertension, and hypertension damage to the retina also occurs. Lungs, pulmonary and skin changes occur. These people have a lot of pruritus as things get worse. The skin is dry. There is peripheral neuropathy as well. A lot of tingling, numbness, so many symptoms. Next slide. Next slide. Yeah, it basically describes the same, the things that I've already discussed. Next slide. So this is stage wise. So things are occurring rather late in the day. It's already stage three to things generally start happening in stage three. They get worse in stage four, and stage five things are already bad. Uh, Next slide. So why are we so concerned about CKD? The problem with CKD is that a person with CKD doesn't live long. He doesn't live long. So even when he goes into dialysis, and you think that dialysis is a great technological advancement and it's keeping somebody alive, well, yes, it is keeping that person alive, but it's barely so. So you can just look at the graph, and what is happening here is, look at the possibility of dying. The moment the GFR goes to below 15, you can see how high the age standardized rate of hospitalization and cardiovascular events and death. Everything is increasing, and increases by several folds with each drop in GFR. With each drop in GFR. In fact, a dialysis person, the average annual mortality in hemodialysis patients is 25%. That is 100 people starting dialysis today. At the end of 1 year, 25 of them would not be around. And what would they not be around because of? They would have died of cardiac disease, 50%, infections, 25. They would have had a stroke in almost 6%. Some of them would just give up on life and give up on dialysis. So that is, this statistics is from the US, not from India. Things are quite similar here as well. Probably people not actually getting dialysis is more in India. Next slide. Next slide. So once you have uh, diagnosed CKD and you have categorized it, you have tried to find the underlying cause, you try to treat the underlying cause as well. And you do a lot of other things. So, one of the things that you do is, if this person, you try to take care to keep the patient safe. How do you do that? You obviously tell them to avoid painkillers that would make things worse. They cause more loss of. These are all nephrotoxic drugs. So these patients are kept away from nephrotoxic drugs like painkillers, and you would like to use drugs which can create problems in these patients very cautiously. For example, an ACE inhibitor or an angiotensin receptor blocker. You don't wouldn't like to combine the two in somebody who has underlying CKD because of the possibility of acute kidney injury and possibility of hyperkalemia. You would tell them something about what is known as the sick day rules. That is, when somebody is unwell, they should try to avoid ACE inhibitors at that time, because apparently the incidence of acute kidney injury increases. Even dapagliflozin, when taken during sick days, apparently can increase the chances of getting acute kidney injury. So acute, so-called acute on chronic. These patients may be candidates for angiography. Your cardiology colleague may have this patient with a high creatinine and he wants to do an angiography because this gentleman has a chest pain. So you have to follow the precautions, that you have to protect them, ensure good hydration, uh, ensure that you use low osmolar contrast media, ensure that you monitor the uh, renal functions, things like that. So at every stage, you have to keep that in mind. So stage where the estimated GFR is less than 30 ml per minute, there are a lot of other things that you need to do. For example, avoid metformin. A lot of our patients are on metformin. Avoid biphosphonates. Avoid biphosphonates, and of course we have to avoid painkillers at all times. One of the things that we always do in our CKD patients is to tell them that they should preserve the veins of their left arm if they're right-handers, so that these veins are not punctured and destroyed. So when at the time of dialysis, when they need a fistula, you can't create a fistula because the veins have already been destroyed. So uh, uh, at my first meeting with the patient, I always caution him, tell him that, not in so many words, that a time will come when you will be on dialysis. These are not things that you tell people, but you do tell them that please keep the veins of your left arm safe. Don't get them punctured by anyone. Okay, so there are a lot of other things that you do to slow down the CKD progression. So that the most important is, of course, control of blood pressure. Apparently, ACE inhibitors or ARBs are the drugs that you should be using, provided that you can use them if there are no contraindications, especially if there is significant proteinuria, even though that in the microalbuminuria range, that is between 30 to 300 milligram per gram. Uh, and to control blood pressures, you may even require diuretics sometimes, because the renal failure, hypertension is associated with fluid plus status. You have to restrict sodium. You have to uh, take care of the glycemic control in diabetics. So there should be reasonably tight control, like an HbA1c of less than 6.5. Most people who have underlying CKD, we tend to start with metformin and an SGLT2 inhibitor nowadays. And if the creatinine clearance dips below 30, we remove the metformin, and obviously SGLT2 inhibitors generally cannot be used beyond 25 ml per minute. Then we tend to shift to a GLP-1 receptor, GLP-1RA, and we do for complications associated with CKD, like anemia. So we keep the anemia, uh, hemoglobin between 11 and 12 at all times. Obviously, you look for iron deficiency. There would be so many reasons why they can become iron deficient, and we can use oral drugs in the initial phases of CKD, but later on, because of so many pathophysiological things that happen in the body, oral iron is not very effective, so IV iron is used. We take care of the acidosis. It has been seen that taking care of acidosis actually retards the progression of disease. You keep the bicarb level around 22 at all times. You have to keep in mind that these people are at particular risk of developing mineral bone disease. They would have secondary hyperparathyroidism, hyperphosphatemia, hypercalcemia, but a lot of others. There is a full spectrum of things that can happen, like for example the low turnover bone disease. Uh, and uh, so you should know how to manage that. You have to supplement vitamin D. You have to take care of uh, the high parathyroid levels, because it has been shown that parathyroid hormone itself, high level of hormone, works as a toxin, as a uremic toxin. And of course, you have to keep these people safe from infection. So you'd like to vaccinate them. We generally vaccinate all of our patients for hepatitis B at first contact. We have to use higher doses in our CKD patients, especially in those with a creatinine clearance of less than 30 ml per minute. We use double the dose, that is 2 ml, four times, four times. Excuse me, please, can you show the slide, please? Hello. Anyway, so these are the things that you need to do, and subsequently what happens is you have to tell this person that he has to stop smoking, you have to take care of his uric acid levels, and at some point when the creatinine clearance is touching is dipping around 25 ml per minute or so, and you feel that dialysis is not far away, you tell them to get a fistula, and the fistula ideally should be created uh, at least 6 months before the tentative, your calculated estimated time of dialysis. Estimated time, it could, you might, uh, it's totally a guesswork most of the time, but you should have ample time so that you, in case the fistula fails, because diabetics particularly, the blood vessels are very bad and fistulas can fail, so you may need to create another fistula. So you'd like the fistula first approach in all these patients. So when dialysis comes, dialysis, what would be the indications of dialysis? Dialysis would be indicated in the CKD patients when the creatinine clearance, when the EGFR is less than 8 ml per minute, even in absence of symptoms. But if it is less than 15 ml per minute with symptoms like anorexia, nausea, with hyperkalemia, which is unabated, with conservative treatment, with acidosis, which is unabated, with actual malnutrition, evidence of malnutrition or onset of neuropathy or pericarditis. These are very late signs. It means there has been a lot of neglect. So at that point, you don't hesitate and you dialyze. You tell them to be on dialysis. And generally, the idea is there are two ways of going about it. One is the hemodialysis, where we use a vascular catheter or a fistula or a graft, a arteriovenous graft, to get the blood inside the dialyzer for purification. This has to be done twice to thrice a week. You should have 12 hours of hemodialysis. This is called hemodialysis. 12 hours of hemodialysis in a week. And you could also opt for what is known as peritoneal dialysis. This can be automated peritoneal dialysis using a machine, or uh, chronic ambulatory peritoneal dialysis being done manually, where 3 to 4 exchanges of 2 liter special type of fluid is put inside the peritoneal cavity by using a special catheter known as Tenkov catheter, and the person is told how to do it himself, and he can do it at home. And of course, the best option is transplant. So transplant is the treatment of choice for all CKD patients, provided there are no contraindications. And what would be the contraindication? The contraindication would be somebody is as a malignancy. He's not even going to live two years or so after transplant. Somebody who has a disease which is going to recur anyway, and there is no way you can treat it. For example, atypical HUS. If you don't have eculizumab and you go and transplant that person, he's going to have recurrence, and there is nothing you can do about it. And then, so these are the people. So if there are no contraindications whatsoever, the person should be advised to undergo a transplant. Next slide. So these are the, I talked about all these things, the requirement for dialysis. Next, next slide. Yeah, this is the CAPD. This is the Tenkov catheter. You have one empty bag and you have a full bag. It is put in. kept in place for 4 to 6 hours, then it comes out and it soaks in all the toxins and it comes out. uh, we can talk about it later. Next slide. Next. Yeah. So everybody who has CKD, advanced CKD, should undergo a transplant. So there is something known as preemptive transplant. That is a person who is in whose creatinine clearance is 15 ml per minute or less, but has still not gone into dialysis. So you take him for transplant instead, before he goes for dialysis, because he would be more better preserved. So these are the contraindications: malignancy, chronic infection, severe cardiovascular disease, sick neuropsychiatric disorders, and extremes of age. uh, I think I finished. If anybody has got questions, they can ask me. Thank you.
Yes, sir. Thank you so much, sir, for giving your important time to us and sharing your knowledge with us and making this session informative one, sir. I definitely think this session knowledge is going to help all the participant doctors on their practice. I have received some question from the delegates. If you allow, can I take this question with all your permission?
Yeah, yes, please go
Yeah,
ahead.
the question is, does increasing olmesartan in patient with chronic kidney disease also increase the urea and creatinine?
Olmesartan. Well, as I
Yes, sir.
said, olmesartan is an angiotensin receptor blocker, right? So, uh, as I said, in CKD patients, ACE inhibitors or ARBs are the drug of choice as far as hypertension is concerned, especially in those who have proteinuria, significant proteinuria. When I say significant proteinuria, I even mean people whose proteinuria levels are above 30 milligrams per gram of creatinine. So even those in the micro range, you would like to give an ACE inhibitor or an ARB. The problem is that you should know how to use it. So if someone's creatinine is, for example, 4 and you're using olmesartan, how does olmesartan work? Olmesartan works by dilating the efferent arterioles. So how does it help the kidney? It reduces the intraglomerular pressure, filtration pressure. So it reduces the so-called single nephron GFR. So because the intraglomerular pressure is reduced, that nephron is going to live longer, but at the cost of what? At the cost of a rise in creatinine. So a rise in creatinine is expected when you are using olmesartan or ramipril or any of these drugs. And however, it has been seen that if the rise is more than 30% from baseline, then you should suspect that there is an additional problem. Maybe the person has renal artery stenosis. Maybe the whole kidney has become ischemic because of the use of ACE inhibitor or ARBs. You are not supposed to continue with the ARB. You're supposed to discontinue it and investigate that person for this particular entities. Also, you should know how to what kind of problems you are going to face. You are going to face hyperkalemia. So when you are using in patients who are having advanced disease, renal disease itself causes hyperkalemia, and if you use ARBs, they would be more prone to developing hyperkalemia. So you should be able to monitor these patients. These patients should be disciplined lot. They should be able to control their diet. They should be able to get themselves tested from time to time. It's only then you can use these drugs safely in this particular category of patients. If you're not sure about the safety, then don't use it. Then don't use it. It can become fatal. It can be fatal for some people who have marginal renal functions. Some people who have a creatinine clearance of maybe 25 ml per minute, and you think that you want to use an olmesartan to preserve the kidney function. Maybe it doesn't make sense because that 25 ml per minute may be because of hyperfiltration. The moment you give olmesartan, that hyperfiltration part disappears and the actual renal function appears, and which may be less than 15. So anybody who was going to be uh, on dialysis maybe 6 months later will be on dialysis today. So you have to weigh the pros and cons, whether you are actually helping the patient or not. It can be used early on in CKD, especially in those who are proteinuric and hypertensive. You can definitely use it. It's going to be very uh, protective to the kidney. Definitely. Next
Okay.
question.
Yeah, sir. Thank you so much for answering and explaining it really well, sir. Moving next, the another question is, what are the methods to evaluate nephroprotective activity of herb in diabetic and hypertensive nephropathy or CKD?
Herbs. Frankly, I wouldn't really like to. Well, I mean, herbs, let's not call them herbs, let's call them drugs. So, if you have a particular drug in mind, for example, when dapagliflozin came, it came as an anti diabetic drug. Nobody had any inkling that it's going to be such an important drug for people who have chronic kidney disease. They also did not know that it's going to be such an important drug for people who have cardiac failure. But then they realized when they started, they used it in patients who were diabetic but who also had renal disease or heart failure or both. And they found that dapagliflozin made a huge difference. So, as I said, when you are looking at chronic kidney disease, the parameters for progression are rising creatinine. The more the creatinine rises, obviously the lesser the function, so the faster their kidney disease is progressing. And number two, proteinuria. So you monitor the proteinuria and you monitor the rise in creatinine. And if you find you're using a particular drug, like we found with dapa, the rise in creatinine was significantly slowed, and the rise in proteinuria was also, in fact, the proteinuria was reduced. So it came as a drug for CKD patients. So people, even if they don't have diabetes but they have CKD, we are using dapagliflozin. Next slide. The next question. I hope I answered your query. That answered your question. Hello, hello, hello. Hello, hello. Hello.
I request all the participants to be here patiently as sir is facing some network issue.
Hello.
Yes, sir. Yes, sir. I think there is some network glitches. Thank you so much. There is a one last question. We will take this question and conclude this session. The question
Okay.
is, sir, what are the indications of for renal replacement therapy in chronic kidney disease?
Oh, I had already mentioned when the creatinine clearance is less than generally 6 to 8 ml per minute, even in absence of symptoms, one can consider telling that person to go on dialysis because or consider renal transplant because things can take a turn for the worse at any time. And number two, if the creatinine clearance is less than 15 ml per minute, plus one or more of the following, which includes person is having fluid overload, which is not responding to diuretics, person is having uh, uh, severe is having hyperkalemia not responding to treatment, is having acidosis not responding to usual treatment, is having blood pressures which are not responding to usual treatment, is developing evidence of pericarditis, is having encephalopathy, is having anorexia, nausea, vomiting, evidence of suggesting that the patient is having neuropathy, peripheral neuropathy. So anything, anywhere, anytime, if there is any evidence that complications are happening, which can only be taken care of by renal replacement therapy, then that should be considered. So that is these are the indications for dialysis and chronic kidney disease. Yes.
Okay, thank you so much, sir, for answering all the questions. Sir, just now we have received one last question, sir. What are the issues may arise from the negative effects of metabolic acidosis in cases of CKD?
Metabolic acidosis Metabolic acidosis is invariably starts occurring when the creatinine clearance is below 45 ml per minute, and once it is below 25 ml per minute, then it becomes worse because initially it is a non-anion gap metabolic acidosis. Later on, because of accumulation of various products, the anion gap metabolic acidosis also supervenes. And so what would happen? It has been seen that with metabolic acidosis, untreated metabolic acidosis, bone disease is worse because there is leaching. The bone tends to do a lot of buffering, so there is leaching from the bones. The bones become weak, the muscles become weak, the heart becomes weak, and the kidney disease also progresses faster if the metabolic acidosis has not been taken care of. So these are the usual things that happen. Also, when there is uncontrolled, very severe metabolic acidosis, then the person's life is at risk because that person can die of fatal arrhythmias because the heart doesn't function well at that time and blood pressures can crash. A lot of things can happen. So metabolic acidosis should be thought of quite early in renal disease, in chronic kidney disease. It is generally taken care of by the body by buffering, but at some point, these buffering is overwhelmed, and you need to take care of it. Yes.
Okay,
Anything
thank you
else?
so much, sir. No, sir. Thank you so much for answering all the question really well and well explained by you, sir. As there is no more question, with all your permission, shall we conclude this session, sir?
Yeah. Okay. Thank you so much.
Okay,
Thank you.
thank you so much, sir. And again, thanks for giving your precious time, sir. And sorry for the
Okay.
technical glitches. And
Yeah.
hope
No.
to see you again, sir. And take care of yourself,
Okay.
sir. Thank you.
Fine.